Thank you for inviting me. I'm from University of Buffalo, and our lab is particularly located in this building, which is called Gates Vascular Institute. It is an entire building dedicated just to vascular disease. There is somewhere in here on this floor about 14 angio rooms, about 4 CT, Aquilion ones for 320 slices, and another couple of MRIs, all again dedicated to the vascular disease. It turns out that in Western New York, we have a real big problem with that. Ironically enough, this building is right across the street from Anchor Bars, where they invented chicken wings. And the rumor is that we have a tunnel going directly to our emergency room. Well, it's not. So these are the people that actually help all this project going. These are Elad Levy, Adnan Siddiqui, Ken Snyder, and Jason Davies. These are the neurosurgeons that the entire data that I'm presenting today, it is based on their work. I'm the medical physicist and a program developer, and most of the talks, most of the data that I'm presenting today is based on endovascular interventions. It's pretty much a procedure based on catheter. It's all catheter based under X-ray guidance. We take the catheter to the place of intervention and treat an aneurysm or a blockage in ischemic stroke. Most of the talk will be on aneurysm treatment. So one of the problems we're facing is during the treatment of the endovascular of the aneurysm or intracranial aneurysm is that here we have a couple of examples. Case A to C. We start treating this aneurysm. In this case, we put coils into the aneurysm sac. These structures have the intention of disturbing the flow and reducing the mechanical forces experienced by the wall aneurysm sac or the wall, and reduce the chance of rupture. And the way it works, they start filling in these aneurysms, and then they look at the blood or the contrast, the injections, and after a while they think, well, it looks good. So, and then they move to the next patient. And the problem is that about 30% of these patients actually do not occlude, and the risk of rupture is maintained. We cannot tell what happened from this point to this point, that actually a 3 month or 6 month follow-up, this aneurysm is gone. This one had a recurrent neck, and this one has quite a bit of filling inside the aneurysm. These scores are in particular called Raymond-Roy scores, and it's a way to classify this aneurysm. Another way to treat the aneurysm is what is called the flow diverter. The flow diverter is a stent. It is a very fine stent, more looking like a finger trap. 64 wires, 32. And it's supposed to actually obtain the same kind of flow modifications without touching the aneurysm sac. And this one supposedly will reduce the chance of rupturing or herniating the aneurysm wall. We cannot use this stent somewhere like in the MCA regions because of the perforators, and you might end actually blocking some of them, though there are more often now reports of people using this stent deeper into the brain vasculature. And again, this aneurysm is gone. This one, there is something left there. This person had 5 aneurysms in particular. And the next one in here, at 6 months, the aneurysm is intact. The question that we have is there anything in this flow pattern after the treatment that will allow us to predict that one aneurysm is going to thrombose, another one is not? And in order to do that, we still rely a lot on the digital subtraction angiography. And during this process, we inject contrast. It goes through the vasculature, but it's mostly structural. And we want to evaluate stenosis, AVMs, intracranial aneurysms, etc. And we want to add actually some physiological content to this procedure. And in order to do that, to add functional information, we use what is referred as parametric imaging, parametric angiographic imaging. And it starts with uploading a bunch of an entire sequence into the angiogram. We do some binning to save computational time, and then we look at every single pixel into the image, into this sequence. And we do some discrimination again in order to make sure that that pixel is corresponding to a contrast injection versus the background, again, to save some computational time. And what's happening as the contrast comes in has this kind of curves. And these curves can be fitted with a function that you see there. And that one actually is a gamma variate function that has been demonstrated to be the response function to a impulse like injection. And then looking at these parameters, we can calculate things like mean transit time, time to peak. In general, it describes various parameters in this curve. Mean transit time will be the half width, half max. The time to peak is how fast the contrast got to this peak and so forth. And every single one is related to some aspect of the flow. And by calculating these parameters at every single pixel in the image, we end making color maps like this. And this is angiographic parametric imaging. You see in here, time to peak, mean transit time, time to arrival, peak height, area under the curve, etc. These are biomarkers that are loosely connected actually with the flow. We have tried to use a mathematical model to use these things to predict an aneurysm occlusion, and it didn't work very well. So, and that is because the data, when you do, for example, these are 50 scattered occluded versus unoccluded aneurysms, the data is all over the place. And when you have data that you cannot model mathematically, the saving grace, then we go to machine learning and look into some of this. There are clusters, and that was for us kind of like interesting, some in there. And we pursued in using this data as in the machine learning context. This is a design of our network. We use an input of five data, which is MPT, time to peak, bolus arrival time, and peak height and area under the curve. There are some convolution layers in here, and at the end, the system is supposed to predict if an aneurysm is going to occlude or not. We used, these are some details about the data that he used, and this is not different from, let's say, credit card score predictors or things like this, if a person is going to pay back his debt or not. This is typically based just on data. And later I'll show you the things that are based on the images itself as well. So it took, we analyzed this data, and here are some of the results. We compare the data that we have. In particular, we have a lot of patients. Just in the last 3 or 4 years, we have over 600 pipeline results treated with follow-ups. We have about the same amount of coils, and having the access to this database is key. And we have about, in the last year, 700 or almost 800 subarachnoid hemorrhages also that we plan to use for this study. So in the moment that we plug in the data, this is kind of the output that the network would give us. The prediction probability is that this aneurysm will be 98% will fully occlude. And indeed, this aneurysm had that immediately. This is, again, it's immediately or during the procedure. The catheter, the interventionalist is still with the catheter somewhere inside the artery and looking to assess if he or she should add another coil or not. And same is in here. This with a probability of 73. The idea is that, are you going to do something now here during this procedure to augment your intervention? And this is where I think it is a very strong tool. The ROC curve for data is here. We do a lot better when we separate per procedure. In this case, if we treat a flow diverter group versus a coil group, when we combine them together, we're not doing that well. So there is a lot of place and room to improve on that. So another thing that we have, our neurosurgeons are very impatient, and when we ask them, how long would you be willing to wait for a result like this? And he said 5 seconds. So about 5 seconds, we need to give them a result, and we need to automatize some of this some of this data. So no user input, because technically you have to go and user outline the aneurysm, then takes arterial input function to deconvolve it in order to calculate the proper data. So since this is pretty much a segmentation, it is very good for automatization. So we took 350 DSA acquisitions. We took adult patients treated for saccular at our center, Gates Vascular Institute, and we used Canon Infinix biplane. So of the 350, with 55 with prior treatment, 45% with coil procedures, and these are the details. They were fairly spread around the circle of Willis and an internal carotid. So these are the kind of the data. Sometimes the patients moved, and we found out that actually there is not a problem with our, and this is a network. We base it on the VG, and then you kind of, when you pull it, you add the pixels together in a certain region, and you keep going at it, and then you go the other way around, and you have the output. So these are the details that we use. It takes about a full weekend, 48 hours to train it, but once you train it, the decision is a few seconds. So ImageNet, and we calculate our accuracy using the dice loss across that were the parameters of the network. And here are the outputs. Here we start with, this is the parametric imaging, and that's what the network predicts that the aneurysm is there. A pretty good agreement. Again, when we have coiled, the network was able to identify the aneurysm and the arteries as well from the background. Again, a pretty good agreement. Motion artifacts have not been a problem. Again, another case, presence of the catheter, not a problem. The network was able to go around and identify them very well. And this is the ROC curves. We've done pretty good in identifying the aneurysm with the area under the curve of 0.798 for the aneurysm stack. These are the Jacquard index and the DICE score, which again, 1 is perfect, 50% is pretty bad. So I'm going to go through these. Some of the arteries, we had some problems identifying them at the periphery, but since we're focused mostly on the aneurysm, that was not a problem for us. So all in all, then we compared what is the ability, how good is the machine learning at pulling out those parameters. When we compare them with the user expert, which means a person measured the same parameters, time to peak, mean transit time, area under the curve, peak height, and it's about somewhere around 15% agreement between the user and the machine, and pretty good correlation as well when we calculate the Pearson numbers. So overall, our conclusion that network performs non-inferiorly to an expert user. So current API method takes about 20 minutes at 1024 by 1024, 5 seconds to train the network. What we are planning into the future, it is to parameterize. The parametric imaging is taking the most time. We would like it to get to the point that everything else is done under 5 seconds on our system. The other thing that we wonder, what is this network doing? We want to make sure that the decision that it's making, it is right. And we break the network, as you see in here, and then we output the weight. What makes the network decide that this is the aneurysm and not something else in there? And these so-called activation maps shows where the weights are the highest. And we see that, yes, the weights are the highest into the aneurysm neck, into the aneurysm dome, which means it takes into consideration parameters, but also their distribution, the gradient. Like here, the outside, the gradient, the curvature, it is one that matters. And now we know that the network is doing what it's supposed to do. And again, we use the VGGs in here, but what we were moving towards is that you see the parametric imaging maps have different structures in there, different patterns of flow. We are not using these as of now. And we are moving towards taking this into consideration. We take the angiogram, nothing else, aneurysm detection, we run the algorithm, get the maps, and we use the maps themselves, the actual images, in order to account for patterns, for impinging jet, for pooling, and so far and so on. And this is, and at the end, again, just give the prediction right there in the angio room on the spot. The final thing that I would like to present, it is on stroke due to large occlusion and delayed cerebral ischemia. We'd like to find out regions where depleted in blood flow, as you see here. Parametric imaging map can do very well. In this case, you see it here. There is a depletion. They did a thrombectomy using a retriever, took the clot out, and then post-arrival timing shows improved flow in the area. So what we want to do it is in real time doing thrombectomy, predict new infarct forms. And this is, we use a different kind of network, the UNet kind of a network. So what do we do for this? We use parametric imaging, but we have a database of MRI, FLAIR MRI, with patients what happened at 48 hours later. So we take the FLAIR, we recreate the views, the projection views from the angio room, and we have the area of the infarct. We take that area and we co-register it with the actual angio. And this is giving us a training data set, the data set that we are using to train the network. A user goes and manually segments the infarct core, the projected infarct core onto the angiogram. And we use this in order to train the network based on the parametric images that we have. Angiographic parametric imaging goes in, it goes through a bunch of training data sets. This is the infarct core that we're using as a training set. And then these are the labels. These are, those are the inputs. These are the labels, how it looks. And this is what the network can predict. In other words, during thrombectomy, when you pull out the clot and you still have delayed flow or infarct cores, the network right away goes and predicts, hey, this area or this area in here is still low on flow. And this, again, it is supposed to be in real time during the thrombectomies. And when we compare with the ground truth, we're pretty close. Now, the ROC is not coming that great as the others. And it's because it's calculated by estimating every single pixel. When we look if it is, hey, did a stroke occurred or not, it is pretty good. But when we look at pixel by pixel, we're still pretty poor, but we're working on improving onto this with different tricks. So overall, our goal is to create a completely independent tool that could be used in angiographic suite in real time to predict treatment outcomes at the time of the treatment. Next step is to implement the technical efficacy and accuracy of the study, and this is ongoing. That's either on phantoms or on real data. So if it's successful, this approach could become a valuable tool to assist neurosurgeons in decision making, and as well based on the real-time neurosurgeons, they can decide what to do next. Depending on the device selection, they can choose to add a second flow diverter or to add more coils, etc. So all in all, these are my programmers, and without these gentlemen down here, definitely they are the data providers, and they have their hands pretty much full on this. Thank you.
Thank you very much. That was very detailed and to the point. I really appreciate that. Are there any questions, perhaps?
Yes.
For your parametric imaging data inputs, what frame rates are the angiographic acquisition?
I would prefer anywhere above 7.5, but we can work with 5.
7.5 frames.
The minimum.
Yeah. That's what I was wondering. It's a very high frame rate. It's a lot of radiation.
We're looking into ways to deal with it. Some of the 3.5 and 4 frames per second might work if we do as showed before recurrent networks.
Are they biplane acquisitions?
Pretty much in neurosurgery, every single one is biplane. Yeah.
So a lot of angiographic systems are disabled to give biplane imaging above 3 frames per second because of the safety concern. I'm surprised you can get biplane acquisitions at that rate. Did you disable the safety mechanism?
Pretty much, we can control everything on our biplane. We have the Canon engineers on site, but I'm pretty sure we can go on the Canon angiographic parameters because, for example, let's take it for AVMs where they need long run and pretty much very, very detailed. They go sometimes at 10 frames per second.
I think that's a little high. I'd like to know what my colleagues think of that.
Well, the other thing is,
I do want to say something about that. So that's very important to consider from a radiation perspective. We do all of these studies under fluoroscopy, and there are, I write a lot about radiation dose reduction, and our routine practice is a variable frame rate. So you don't have that fixed frame rate. You use the higher frame rate in the arterial phase where you need that dynamic information, and then drop it down to a slower rate in the venous phase where you don't need that stratification. And our routine is the variable frame rate from 3 frames per second to 2 frames per second. For AVMs, for selective images of the particular feeding artery that goes to that vessel, then we'll do like 6 frames per second. But the radiation doses can be I'm shocked at the dose of frame rates of 7.5 for the whole thing. I think that should not be considered for like the whole study, and you should use that selectively and be very careful because these are additive. And it's not just the one. These people will have multiple procedures.
Yeah. Though there is another aspect of the stroke, and it's particularly subarachnoid hemorrhage and ischemic stroke. It's a do or die for that patient. You do your best job, or there is no one to do it.
No, I agree, but it's completely achievable with a lower frame rate. Yeah. So I would just say, be considerate about those things because we do understand the severity and necessary intervention, but they are completely achievable at lower frame rates. That's the point.
So that brings the question whether you can get this information in the future at lower frame rates. Is that possible? Because what you're showing is very relevant, especially for both stroke and aneurysm. So do you see this evolving to where you can get this information at lower frame rates?
The idea would be for us to actually step away from time density curves altogether. If we can go to recurrent network. And the recurrent network is very nice because it doesn't take into consideration the very fine details of the curve. For example, how it does it on breaking movies. You give every word a certain weight. And based on that, this is a good review or a bad review, how those sequence of numbers comes along. So we are thinking that recurrent network actually might be a better way to do it. That's literally, we just started running like 3 weeks ago, and might be able to go around with less frame rates.
This is really lovely data. I mean, a terrific job there. When you got to the end, you said you want to develop an independent tool. So I'm a kind of practical engineering kind of physics guy. And I'm thinking, well, what is that? What does the tool look like? Is this a box that you bring into the scanner, or?
It's no, it's an imaging tool. Technically, we would like, right now it's still quite a little bit of manual input in there. First, someone has to run the parametric imaging, then it goes and outlines, this is the ROI of the aneurysm, this is the arterial input function, and then it calculates farther. And we want to take that part when you have to stop the procedure to do all this manual work on the software to be taken apart.
So the problem is, or when we try to deal with this, say in MRI, which is where I've been working in, is that you have to hook up with one of the scanner manufacturers, or more than one, or all of the scanner manufacturers, because they're not going to voluntarily go and make the multi-GPU system to be able to do this straight away. So actually, it might actually be a good idea to think of a box that you take in, put it there, hit the protocol, and press the button, and out comes the result.
Every single X-ray system has a CAN network, which is controlled area network, and we kind of hijacked it. So we tapped into it, and where the imaging goes, we put a splitter and we double the data and we send it to our NVIDIA station. So we got into their stuff, and Canon was in particular okay with it. So pretty much we're integrated. The research tool is integrated into the system itself.
Thank you very much, Ciprian.